Well, welcome everyone. This is our September Cup of Tea event. This event occurs 4 times a year and is intended to bring the Canadian retinoblastoma community together for an informal discussion and research. This is similar to a journal club. So grab a warm or cold beverage and join us for this hour. My name is Ivana Rostevsky and I'll be your host this evening. So just a reminder, our event is taking place during the first half of the tumor board meeting. So we will try our best to finish the presentation by 9 p.m. So anybody who's attending that meeting would have heard all their discussions and presentations. And anybody who wants to stay longer and continue having a conversation, we can do so, and I will stay later. So the agenda for this evening is I will share some announcements. I will share some parent and research updates. We will then go into the article summary and then have our community discussion. So as we begin our event, please keep your mic muted and keep your camera on just to keep the spirit of a community event. And if you encounter any issues, please send a message through chat to Roxanne, or you can send an email to retinoblastoma.research@sickkids.ca. So for our announcements, I usually share about the retinoblastoma research community just to make sure everybody is aware and knows how to join if they haven't done so already. So the retinoblastoma research community was created to connect people who are professionally or personally connected to retinoblastoma and are also interested in research. We also encourage international sign-up for all retinoblastoma patients, which includes family and friends, researchers, and health professionals. To join, you could visit our website, rbcanadaresearch.com. Now, I encourage all of you here to sign up if you have not done so already. If you're not sure if you have signed up, just contact me and I will check for you. And being part of the research community is the best way to stay informed of opportunities, events, and so much more. If you're personally connected to retinoblastoma, share this information with your family and friends and with your care team. And if you are a health professional, share this with your retinoblastoma families and colleagues who care for those families. You could also invite them all to our next event, and that way they could experience the community for themselves. Our next announcement is about getting involved in addressing one of our research priorities. In 2017, the top 10 retinoblastoma research priorities were established, and priority 3 looks to address the psychosocial needs of retinoblastoma survivors and families. And we launched a study to address this priority. So we're looking for participants to help in evaluating psychosocial needs of retinoblastoma patients and families. And you can help by filling out a questionnaire if you're a retinoblastoma parent or survivor and are over the age of 16 and had at least part of the treatment done in Canada. And if you don't fit that criteria, you can share this survey with others so that they can help out with this study. So you can email retinoblastoma.research@sickkids.ca for more info or the link that's provided in the chat. The next announcement is about the Patient Advocate Committee for the Rare Pediatric Eye Cancer Biobank. The Rare Pediatric Eye Cancer, or RPEC, Biobank invites all those with lived experience to attend and contribute to the first biobank dedicated to RPECs. The meeting is on Tuesday, September 26th at 8 p.m. Eastern Time. This information would have been shared in our September newsletter, so you can access the link there. Or you can email retinoblastoma.research@sickkids.ca for more information. And some parent and research updates. I wanted to share with you guys the plan for next year. We usually have our retinoblastoma research symposium weekend meeting in January. Now, in this coming year, it's going to be a little bit different. We're going to have the annual general meeting for the Canadian Retinoblastoma Research Advisory Board, open to everyone to attend and encouraged everyone to attend on Saturday, January 20th, which will be a virtual event only. And then the symposium will be happening on Saturday and Sunday, April 20th and 21st, which will give us a little bit more time for networking and alleviate some of the challenges we had faced in January, such as bad weather, perhaps, and travel timing. So hopefully the April weekend will work a bit better for this year. But do remember there's 2 separate events instead of the one for 2024. Now, the last event of 2023 will be our quarterly meeting happening on Saturday, October 28th at 12 p.m., so noon Eastern time. And this event has been happening at different times throughout the year to offer everyone in our community the opportunity to participate at different times. So this one is the Saturday event. The 2023 Retinoblastoma Research Symposium recordings have been posted and have been available. You can find them on our YouTube channel only, Retinoblastoma Research. And a little bit more about our past Cup of Tea events. So I wanted to share with you, now that we have completed 10 events since March 2021, this is our 11th event. In these 10 events that we've had, 105 individuals had attended at least one event. And of these 105 individuals, the breakdown of their relationship with retinoblastoma is as follows. We have 36 individuals with lived experience, 43 that are health professionals, 13 that are researchers, and 13 that are other. Of the health professional attendees, we have every role represented, but the ophthalmologists are the largest group. So thank you for participating and supporting this event. For the other category, it includes unknown relationship to retinoblastoma. Sometimes folks might not have their name on in the Zoom when we are recording all the attendees. So we're not sure who some folks might be. And also some RB advocates who do not have a direct connection to retinoblastoma, but are still interested in learning about the Cup of Tea or supporting the community. For the research attendees, I just want to acknowledge that I know a lot of our ophthalmologists are also researchers, and they have been counted in the health professional bucket. If anybody knows more researchers who are researching topics related to retinoblastoma, invite them to future events so we can continue having these lively discussions. So for this Cup of Tea today, we're going to be discussing the article Group Medical Play and Children's Self-Reported Fear in the Pre-Operative Setting. The plain language summary of the article is available on our website. And the plain language summaries of articles are all created by a patient partner and a non-patient partner. Our partners for today's Cup of Tea are Lindsay Robinson, Morgan Livingstone, and Jocelyn Laworthy. Lindsay Robinson is our patient partner. She's a mom of a retinoblastoma survivor and is interested in the psychosocial effects of treatment. Lindsay is an active member of the Canadian Retinoblastoma Research Advisory Board and frequently attends meetings and events. Morgan Livingstone is a child life specialist with a focus on retinoblastoma. Morgan is a longtime member of the Canadian Retinoblastoma Research Advisory Board and leads the child life program at the annual Retinoblastoma Research Symposium. And most of you have met her through that event or other CRAB events or other events that Morgan has attended or hosted. Jocelyn Laworthy is a child life specialist who trained with Morgan. Jocelyn helped with a child life program during the past retinoblastoma research symposia and has volunteered at the retinoblastoma table at the eye clinic in Sick Kids prior to 2020, which some of you may recall we've had child life attendees helping with crafts while discussing retinoblastoma research with the parents. So I'm going to pass it over to Lindsay Robinson now, who's going to share the summary of her article.
Thank you, Ivana. First of all, I just want to say thank you to CRAB for asking me to host, to work alongside the group to host tonight's Cup of Tea event. So a little bit about my family's story. So my name is Lindsay, and my daughter Olivia was diagnosed with unilateral non-hereditary retinoblastoma in January 2021 at the age of 3.5 years. Her treatment included 3 cycles of intraarterial chemotherapy, 6 weeks of chemoplaque and surgeries for a detached retina, cataract, and tumor extraction, as well as numerous exams under anesthesia. In the spring of 2023, she transitioned to the eye clinic at Sick Kids for follow-up appointments and monitoring. And Olivia has been treated over these last 2.5 years by the Sick Kids retinoblastoma team, led by Drs. Galley, Malpatna, and Dr. Kleckby. On the next slide, on this slide before we move on is just a picture. I just want to describe the pictures here. It's a picture of myself and Olivia that was taken this spring. On the next slide is a picture of Olivia from a photo that was taken this summer at the beach. And so I related to this article for the Cup of Tea because over the course of Olivia's treatment, for 26 months of treatment and surgery, she had visited the pre-operative waiting area at the hospital 27 times in preparation for procedures requiring general anesthesia. Quite often, this was a very upsetting experience for her, as she would become anxious, irritated, and scared while in the waiting area, and often to the point of hysteria after administering eye drops and pre-anesthesia medicine. I was interested in the results of this article we're going to discuss tonight because I often wondered, had my daughter been exposed to medical play with a child life specialist while at the hospital and prior to her procedure, would it have provided her with a less traumatizing hospital experience? I was also interested in this article because when we attended the 2023 retinoblastoma research symposium, she had a very positive medical play experience with Morgan and her team. And this was her first interaction with child life specialists and exposure to medical play. So moving on to discussing the article. So the article was titled Group Medical Play and Children's Self-Reported Fear in the Pre-Operative Setting. So a little bit of background on the article. The article was we completed a plain language summary and forms the basis for our discussion tonight. Was written based on a pilot study conducted at the Monroe Carroll Jr. Children's Hospital at Vanderbilt, Nashville, Tennessee. The purpose of the mixed method study was to explore the impact of group medical play intervention on children's self-reported fear and their observed anxiety by a child life specialist, while also considering whether offering group medical play intervention as a clinical or research intervention was feasible within the bounds of a typical child life staff setting while balancing clinical care. Although other studies have highlighted the benefits of medical play within a pre-operative setting, these studies have only included one-on-one medical play sessions provided in the days leading up to the surgery rather than the day of the scheduled surgical intervention. So the authors of this article sought to address the following research questions. How do young children in the preoperative waiting area experience group medical play intervention facilitated by a child life specialist? And what is the feasibility of offering group medical play as a clinical or research intervention in the preoperative setting? The study was conducted at the Children's Hospital, as I mentioned before. The site surgery department serves approximately 90 to 100 patients per day with a diverse range of diagnosis and surgical needs. In that preoperative hospital, there are 2 full-time certified child life specialists who provide coverage to preoperative services 5 days a week for 9.5 hours a day. Participants in the study included children, 11 male and 9 female, ages 5 to 10 years, and the median age of the children in the study was 7 years, who were awaiting a sedated surgical or medical procedure in the preoperative services waiting area. On average, the participants had previously undergone 3.5 surgical procedures and were scheduled to undergo a range of surgeries or procedures, including dental, eye, ear, nose, throat, gastrointestinal, cardiac, or other surgeries. At the end of the 30-minute play session, a member of the research team asked the child to answer 3 open-end interview questions about the play session and to indicate their fears about surgery prior to and after the medical play intervention, using a 5-point pictorial fear assessment scale. This was the children's self-reported fear portion of the study. So on the screen here, in the first image, the image on the screen here is the pictorial scale that the children were asked to look at. So we have 5 different happy faces here, ranging from very sad all the way through to happy. For the observed anxiety portion of the study, a member of the research team observed the child as they approached the group and began to observe the play and assess the level of preoperative anxiety at that moment in time using the modified Yale preoperative anxiety scale. I'm sorry, on the So for the results of this study, the average YPAS score was 5.65, with a low scoring, with a low in this would be considered a 5, and a high was 22. So on the range of the observed anxiety by the medical researcher, it was scored as low at a 5.65, and that reflected their overall anxiety from start to finish of the observation time. Children reported an average fear rating of 2.35 prior to the medical play intervention, and children reported an average fear rating of 1.7 after the medical intervention. So again, a scale of a low rating would have been a 1, where they considered themselves very happy, and then a 5 would have been that they considered themselves to be very afraid. They were also asked open-ended questions, and the results of those open-ended questions were that 90% of the participants reported positive feelings about their medical play experience, and 40% of reported feeling positive when asked how they felt about their scheduled surgery that day. And I'm not surprised by the results of this study. As a parent, I could see that and the experiences that Olivia had that after, being in a medical play setting, doesn't surprise me that children would have felt, less anxiety or fear going into the procedure, having been exposed to some medical play. So no real surprises here in terms of the results of the survey for me. And then what we wanted to do with this was also look at the results of this study and compare it to what the RB journey looks like. So in this study, participants were aged 5 to 10 years. And how is this similar or different to the retinoblastoma journey? So with retinoblastoma, often the patients are diagnosed under the age of 12 months, but can range all the way through to, and then their treatment ranges all the way through to adulthood. There is a wide range of surgeries or procedures that were taking place with the participants in this study. And as I noted before, it was dental, eye, ear, nose, throat, and cardiac. However, on the RB journey, there is a range of procedures or surgeries that can happen as well. However, they are all related to the eye. So some different types that our RB patients would experience in the preoperative area they might be waiting for is enucleation, chemo, EUA, eye exams, eye drops, and imaging. In this study, it only looked at the observed and assessed in the preoperative waiting area, whereas with RB patients, we know that treatment takes place in many different locations, within a hospital. So sometimes patients are going to visit oncology to meet with the oncologist for tests. There's the pre-operative area, visits to the eye clinic for eye exams, as well as visiting the ocularist office. And then finally, this study only included medical play and observation of the patient, whereas with our RB patients, we know that they are often supported by family, various family members, including parents and siblings, who may have their own fears and anxieties. So in this study, I think the observed fear was and anxiety of these children was rated fairly low. But I think often, sometimes with our RB patients, because they are sometimes at a younger age, sometimes the anxiety and fear is more in the parents and can be more in the parents and in the siblings. So just a chart here that looked at comparing some points that were raised in the article through to how that relates to our own patients in their RB journey. And next, I will pass it off to Morgan and Jocelyn to present on their child life experiences.
And Lindsay and I will get together and make magic for the first half, but
I'll redo it. No problem.
So Morgan and Jocelyn, we're ready to hear your child life thoughts and experiences.
Excellent. So I'm going to start it off with us. So when we're talking about what child life is, so Morgan and I are psychosocial professionals that are experts in child development. So we use play-based and creative modalities to be able to support children where they're at, to be able to help reduce stress and anxiety that them and their families might experience as it relates to their medical experiences and hospitalization. So we also use these modalities to promote effective coping through providing developmentally appropriate education. So whether that be for a new diagnosis or providing step-by-step preparation for a medical experience that they're going to have happen, support during a procedure, so distraction, and all of these modalities are provided through play and meeting children where they're at to really help empower them through these experiences. Next slide, please. So when we're talking about child life interventions, especially like, for example, compared to the article when they were exploring group play-based interventions, in the context of, supporting children with RB, thinking about group versus individual. So the CRAB Symposium, for example, Morgan has had a fantastic program that she's run every year that when we look at a group intervention, for example, it's open-ended. We might be providing children with an array of both real and pretend medical equipment to allow them to be able to explore. There's not necessarily a specific focus to it, but it's a really great way to allow children to become more familiar. It desensitizes them and allows them to explore in a way when they're not in that acute medical appointment where they might have experienced that distress and this discomfort. They might learn from other children, so they might interact in a lot of different ways. So maybe they're learning from peers who are modeling about experiences that they've had before, or they're playing around and learning how to be more comfortable with a prosthetic or to do with eye drops and patches. So lots of different things to gain from group interventions, but individual interventions are also modalities that we use as child life specialists to be able to support children in their individual needs. So whether that be supporting a specific fear or anxiety related to something a child might be going through, so preparing them for an EUA and maybe helping desensitize them to the mask. So we might be specifically focusing on that, maybe where allowing them to explore with it and practicing deep breathing with bubbles through the mask and having some fun with it in that regard as well. So those are just kind of breaking down the different ways that we might be supporting. Next slide, please. And then when we talk about child life in the support of RB care, there are definitely some important issues and challenges that we have to be able to highlight as well, especially considering the nature of RB treatment and care. A lot of children are seen on an outpatient basis, and at a lot of the children's hospitals and medical facilities where they're receiving care, there's a lot more resources in child life allocated to inpatient care. So sometimes patients and families get missed based on, not having long hospital stays. and having day surgeries and whatnot. We're also talking about a lot of infants and toddlers. And when it comes to this population, they are definitely underserved to begin with. I think there's a lot of professionals that maybe have discomfort or maybe not the confidence or experience, and often their needs are undermet. But then also the knowledge and ability to understand how child life specialists can support this population. So not everywhere has access or understands how they can access the support. People don't know what they don't know, and that can be a challenge in itself. But then also in the child life realm of things, I'm very fortunate that I've had such great experiences being trained under Morgan to learn more about RB and how to support the specific needs of our patients, but not everybody has this experience and training. So when we think about future directions, Morgan's going to talk more about that, but there's definitely a need for holistic support. So just like that group medical play, not only is it beneficial for patients, but also for their siblings that are curious and would like to explore and learn. That's how children learn and make sense of their experiences, and that's the same for siblings. It can also make parents feel more comfortable. Everybody's impacted by a diagnosis in similar and different ways, but then also making sure that there's more education for both child life specialists to be able to meet the specific needs of our RB patients. It's definitely also something for teams to be aware of, how we can be an asset to the team and to be able to support the family needs. So I'm going to hand it over to Morgan for some of our next slides.
Great. Okay. Thank you very much for having me, and Lindsay and Jocelyn, great work on presenting this research. I'm especially excited about the fact that it does validate what we know, is that children do benefit significantly from preparation through medical play before a procedure or a surgery. So when we look at the child life needs of the patient, so usually very young children, as Lindsay explained, typically under 5 years of age when diagnosed, you can still prepare an infant. As you can see, here's my little friend, Audrey. She is not afraid of that mask. In fact, she's making friends with it. So I think part of what we really want and our goals for retinoblastoma and child life for even our youngest patients is that they also be included in medical play and preparation. It helps build coping skills. Audrey was 10 months in that picture. Yes, Emily is Audrey's mom. And you can see that there's benefits even for our youngest friends. When I say building coping skills, it's around tolerance. It's around teaching children to read your cues too as a parent. And as a care provider, like a child life specialist and the different medical team members, play of any sort helps children. So when we talk about play in general, we want normalizing play. So children, just because of a cancer diagnosis, should not be limited or driven away from play just because of the serious health needs that they have. But if anything, they should be offered more play, more opportunities to de-stress through play. Medical play also, as you can see in this picture of Audrey, is a really great way to familiarize children with what's going to happen, the types of equipment that they might see, and the things that they might feel or smell or taste in their healthcare experience. When I mention that the needs of the patient include comfort and pain management, there are many simple techniques that we can do, non-pharmacological and pharmacological, that help manage children's pain. Wonderful accompanying pain management strategies include things like infant massage, which is perfect for our youngest patients with retinoblastoma. Comfort positions as well really benefit children, especially with retinoblastoma during the eye drop experience. So there are comfortable positions that they can feel more confident and safe in when they're receiving their eye drops. Parents, of course, and family need to be able to support their children as well. And oftentimes it's best if they have someone to support and lead them in ways that they can help their child if they're nervous themselves or anxious about what's happening. And of course, child life support should be sought out as much as possible if it's available and accessible within the institution that you're working in. Unfortunately, it's not consistent across all areas. Thank you, Ivana.
if you could just help our folks who maybe are listening or can't quite see
Oh,
the
that's right.
picture.
It's not just Audrey. My screen of everyone else's faces is covering my other little friend who's Lincoln here. And Lincoln is 2 years old, and he's actually practicing the eye drop experience on Sunny, one of our medical play dolls. He worked very diligently on practicing and supporting this medical play doll during her eye drop experience. He coached her and said, "Blink, Sunny, blink your eyes, take a deep breath, you're okay," and coached this puppet through the eye drop experience, just like he'd been working on with me during the time of our medical play. And the picture of Audrey is her chewing on a sedation mask. In the next slide, we have the retinoblastoma child life offerings for families. For parents, of course, you know, we need to acknowledge and assist them with their own fears and worries about their child's cancer diagnosis, the treatment that they'll be enduring, the procedures that they'll be undergoing, and of course, possible surgeries. Helping parents build coping skills for themselves and to support their child often involves education and information, being able to allow them to share their feelings and fears openly and provide different strategies to help with de-stress, and also acknowledge that stress is a natural part of dealing with family illness and a child's illness, and that there are strategies that they can use that will help reduce their stress and allow them to offer better support to their own children. With siblings, as you've heard many times throughout this, Lindsay and Jocelyn and I are big fans of siblings being included, and they deserve education and information at that age appropriate and developmentally appropriate level about their siblings' diagnosis. They should also have open access to medical play, which helps them understand what's going on, as well as promotes their coping with what can be a very complex and scary time while they are supporting their sibling at the hospital during their appointments. I want siblings to always feel included in the RB experience. And by having our group play offerings within the CRAB and World Eye Cancer Hope settings, we welcome siblings and their ability to participate alongside our youngest patients. Access to support group programs also is available, often quite widely in the community through different cancer support groups. In Toronto and across Canada, we have different parts that offer Gilda's clubs, which have play-based cancer-focused work for siblings. There are other programs too that are available in the United States called SIBS clubs, and many others that are just locally run. So it's worth looking into that there may actually be access to free support programs for siblings. In these pictures, we have a group picture, sorry, Ivana, of one retinoblastoma patient and his sister and a friend all playing with a very long-trunked medical play elephant during one of our CRAB medical play sessions. And I have a picture of myself and Genevieve, the head of the Canadian Retinoblastoma Society, who is a retinoblastoma survivor and parent as well. Thank you. So where do we go from here? My hope with a piece of research like this and our discussion and having future journals focus on children's coping needs, I'm really hoping that we can advocate with real data now for preoperative play programming, medical play, and also play for de-stressing, to allow children to have better overall coping outcomes and reduced anxiety, like we can see from this lovely piece of research. I'm also hoping that we can advocate for access to child life specialists and different supports that should be made available to retinoblastoma patients, of course, and their families. We know from the research that there's a measurable difference in the outcomes for these patients over 5, and I'd love for us to be able to offer it for children under 5. We, of course, want to continue offering educational courses for child life specialists to build skills in retinoblastoma supports, and I do my very best, and Jocelyn as well, in continuing to educate our colleagues and friends and ensure that they are learning how the unique needs of retinoblastoma patients should not be overlooked. That often takes place through CRAB, the Canadian Retinoblastoma Society, and also World Eye Cancer Hope. I also really urge retinoblastoma programs to hire certified child life specialists. You heard Jocelyn say my favorite statement, which is, you don't know what you don't know. And many teams don't know until they've seen it. And I know I'm talking to people here in this group that once they've seen the benefits of child life, it's significant the impact it can have on children and their families. And I'm urging retinoblastoma programs to find the funding to hire child life specialists to provide this very unique and specialized support to our youngest friends. And of course, we want to continue to complete more research on retinoblastoma patient support needs. There's been a number of studies that Ivana and the Damaris Lab have undertaken in CRAB, and I'm hopeful that we can continue to offer more and complete more research. In this picture, we actually have one of our collaborative aspects of our CRAB meetings, where we were working together with one of our young retinoblastoma survivors to come up with the stickers for our journey maps. And here there's an artist and one of our young patients, and she's actually drawing and creating the stickers that relate to our journey maps. All right, now the community discussion. There you go, Ivana.
Thank you so much, Morgan and Jocelyn, for the child life perspective, and Lindsay for the really great summary of the article and for you sharing your story. And so I would like to open the discussion up to everyone who's here and attending to share your feedback, or what did you think about the article? What did you think about child life from your experience, or from what you wish you would have had? I have some questions here to help us get going. You could put your hand up or just unmute yourself and just jump on in. But I welcome everyone to start chatting. While you're thinking, I'll read out the questions. For anyone with lived experience, you could be a survivor, patient, family member, anyone who has experience with retinoblastoma. Has your child participated in group play? We'd love to hear about that. How has your experience been in the waiting room? How have you prepared your child for their appointment, whether it was the OR or eye clinic? What are your child's biggest psychosocial concerns related to RB medical experiences, and how can they be better supported? Are you surprised by the level of anxiety reported in the study? And what do you feel your child could have gained or has gained from taking part in group medical play with a child life specialist? Any health professionals that are here, maybe some things you could think about and have a conversation around is, what do you perceive to be psychosocial concerns for your patients during their medical encounters? How do children arrive to the OR, and how are different situations handled? Is there anything that you have noticed that make a difference? And what experience have you had that with offering support to children before procedures, and how does your experience compare to the study? And what process or criteria is used to ensure psychosocial support is offered to your patients? And any researchers here, maybe you could help shed some light on how does parent anxiety compare to the children's anxiety for retinoblastoma?
I don't see anyone raising their hand yet, so maybe I'll just kick it off if I can with an experience in medical play for us. Olivia, I had ordered her Ellie the elephant, and I think some of the parents here will be familiar with Ellie, and because I had seen it through Instagram being shared on someone's feed, so I thought, that's pretty neat. I'm going to get that for her, and it's a stuffed animal that's really related. I really felt like directly to retinoblastoma, and so when it arrived, I was really excited. I ripped it open, I took it out, and I showed her. I took the eye out of Ellie, and it immediately made her really upset. She was scared. The stuffed animal had scared her. She then thought that she was going to lose her eye because of how the elephant was, and so I did not approach that right. But what happened was she came to CRAB, and they had Ellie there, and so in the playroom during the symposium, she was exposed to Ellie in a different way, and she played with her. And just on Sunday night, she actually was going through stuffed animals and got her out and brought her to bed. And so now she uses that elephant as comfort. But if it wasn't for the medical play that she had, and I think, you know, being explained things in a different way, and obviously taking a softer approach to it, you know, it made a difference to her. And now she's not scared of that elephant, and I don't have to hide it in her closet away from her, but she's embracing it. And, you know, it's her new favorite toy. So.
Nicola here would like to share something too. Go on, Bobby. What did you like about Child Life?
I like that there's a lot of like fun like medical toys because it's fun to play with and learn about them. And I also like that it's a long time that I get to be in the room to learn about it. That way I get more learning time to be with these like fun toys that are very interesting and that have been used in real life at other parts of the world or other parts of Canada on other people.
Thanks.
Mm-hmm.
Does anyone else have experiences that they want to share, what they have participated in or what has helped them, or maybe what they wish they had to help them?
I can share. Can't see myself, so there I am. I'm Emily, and this is my daughter Tala. She does not have retinoblastoma. Our daughter Audrey had retinoblastoma, and she's one of the unfortunate rare cases that then metastasized, and she had stem cell transplant. She was the one in the picture at 10 months old. She had the privilege of working with Morgan here in the US. And long before she had words, she could describe her experiences with her EUAs. She was diagnosed at 4 months old. And at about 10 and a half months old, she could describe what was happening. And without any prompting, after getting a mask from Morgan, she would take the mask in our playroom and put it on top of one of her baby dolls' mouth and nose. That was without any prompting or going over what was happening. She did that all on her own one night. So she very much was aware of what was happening before she was able to explain anything to us with words. And then when she had her metastatic disease, she still didn't have a whole lot of language yet that developed as she went through those treatments. But the medical play greatly helped in lessening her anxiety. She was having a lot more procedures done. She would be able to, we could go over MRIs and scans before she needed to have them, and all of her pokes and prods that she wouldn't normally have with just her EUAs. And it really lessened her anxiety. But she would lay down in our playroom and describe what it was like to go through, start going through an MRI or a bone scan. And she's 2.5 years old there, and she would play with her baby dolls. And so it really did, those just few days with Morgan and then connecting with her over online through, here's the situation, what would you suggest, really did help. Unfortunately, where Audrey was treated, they didn't have Child Life. And part of it was just because all of their appointments were so early and they didn't have contracted Child Life that early in the morning. So I think Canada has a one-up on the US a lot of times when it comes to these kind of services, because you have a centralized medical system. But if you don't have a Child Life specialist, check, is it because of the schedule? and how could we work in getting this child life specialist on an earlier schedule so they could better support our kids who might be coming in really early for appointments. So thank you. I appreciate you letting me join from the US.
I think it's great, Emily, and I appreciate you sharing how young Audrey was and how impactful medical play was, because I truly believe even younger babies with retinoblastoma really can benefit from the sensory experience of playing with that mask and being able to see that it is not a threatening piece of equipment, but gaining mastery and a familiarity, just like Audrey did. And also including Audrey's brother. She had a big brother as well who was able to join us, and he was able to model with the play that it was not threatening and that he could master it as well. So always making sure that the siblings included. And Emily and Audrey actually did get to meet Jocelyn too when she was my intern, because we were able to visit them in the US for a conference. So we got to do a little bit of extra medical play then. But I did notice that Catherine Patton had posted a question. How can Child Life say anything about how to get support for child life at hospitals? So you do, as Emily was mentioning, you do need to ask for a referral for child life. Sadly, most of the eye clinics and the pre-op areas don't have a full-time child life specialist. So you'll usually need to ask for a referral. You can do that. I know that at some hospitals right now, child life is considered on call for the eye clinics, so it's worth a try. I will also say, though, that not a lot of child life specialists have experience in retinoblastoma. So you might get a child life specialist, hopefully, but you may have to help them understand what kinds of things your child would benefit from as far as coping support and what they might need to help them be and feel successful during their appointment. The terminology to use would really be, you would like a referral for a child life specialist. Which is also tricky because sometimes retinoblastoma patients are almost exclusively outpatients. So that can be a difficult and challenging issue because not all outpatient clinics have a child life specialist. But again, the worst thing someone can say is no, so ask. I think that the network of child life specialists in Canada and the United States is quite large and a little bit difficult to like navigate, but the best advice would be to contact the child life departments at the hospital that you're working with and ask to speak to someone on the child life team about how your child could access child life and the supports available. An additional option is that there are sometimes cancer specific charities here in Toronto and in Calgary that I know of in Canada, and many across the United States that offer child life support programming for children with cancer with any diagnosis. So sometimes it's worthwhile to look in your community as well.
Thanks, Morgan. And that was my other question, was sort of oncology our best option? Because there were child life specialists in the ORs, and then I haven't seen them for about 8 years.
Yeah, and I think sometimes when there's changes in management and in funding and things like that, sadly, there's a breakdown in understanding that this is an essential service and that children and their coping is an essential part of a child's healthcare experience. So we do need to be saying those things. You know, we do need to be saying, I saw a child life specialist 8 years ago in this OR area, and I'd like that child life specialist to be back here. So the more we ask, the better, hopefully, the better knowledge we have about how to access services.
Do any of our health professionals want to share their experience of maybe how different ways the children have come into their appointments and how having a support beforehand has helped? Or maybe a scenario where you wish somebody was there to help?
I'd just say a brief something that takes off on what we were just talking about with Morgan, that I sometimes feel like a retinoblastoma warrior where the rest of the system isn't entirely lined up on behalf of the child, and the experience that allows the child to be a known individual undergoing repetitive process, as opposed to a one-off single encounter, which seems to be what the system requires, is really profoundly impactful for the child and for the family and for how things are handled. And it's greatly disturbing to watch them get treated as if they were somebody who's never been there before, as opposed to supported for the fact that it's repetitive. And it's any advice, any resources people have, I'd be, really pleased to hear about, because it has become kind of a system issue where when we ask for those things, it's seen as disruptive. And yet it's so essential for the families. I think they do so much better. And I think seeing a familiar face is always, always really important, with a familiar question, and however that has to be presented. Thanks.
I wanted to respond, Catherine, because I think sadly, one of the biggest problems we have with this negligence of child life support for retinoblastoma patients is because they're usually quite young and typically an infant or a toddler. There is this outpouring of support now in these preoperative settings for children with typical, quick, like you're saying, quick, outpatient procedures where they just come in for a short period of time and then they're gone. But retinoblastoma infants and toddlers are largely misunderstood, I think, and because they lack the words and the ability to say, hey, you know what, I didn't like it last time you did this to me, and I don't like it this time. Because they lack a voice, I have been trying for decades to be that voice, just like you've been too, Catherine, and many of us here on this panel, because they are largely ignored in healthcare. We can hold them down, we can get it done, and they can't really explain their experience to us. So we have to be their voice.
There seems to be quite an effort and an emphasis at the moment on pain, recognizing and managing pain, and understanding that that's part of the experience. And I think that's a great step forward. But its negative impact is that eye drops don't get done. Or they may get wafted near a child, and there has to be some other way of doing that that's better. But everybody on the call knows that. And if they've been in sick kids, they've had the advantage of watching it well done. So hopefully, Morgan, we're going to get you helping other people to figure it out and do it better. Thanks so much for your advice. And thanks to all the families for sharing their experience.
Well, we are just out of time. I wanted to ask if anyone had a comment about that anxiety rating. So in the study, they had reported that children didn't really have a really high anxiety going into the OR. And I thought that was very interesting. I would have expected that they would have had a lot higher. And then I think that comes down to the conversation we just had, is the retinoblastoma kids going into the OR are usually babies. And that's what I remember with our experiences, that it was very stressful, but it could have been that you can't communicate, you can't get, explain why, it could be something like we can't eat, so they can't even explain. You'll have food later when it's a baby. Did anybody else find that interesting or surprising that the study showed a low anxiety amongst those children? And just a reminder, there's like a minute left, so a quick response.
I think a lot of that can be attributed to these children have never had a medical experience. So they don't know what they don't know. And then all of a sudden they arrive and there's this lady offering them play. So we don't know what a family's explained to a child beforehand, but these were ear, nose, and throat, tonsils, tubes in the ears. These were minimally invasive procedures, albeit under sedation. But I I would assume that the reduced anxiety to start with was probably attributed to the fact that the child didn't really know what they were going into anyway.
Well, thank you guys so much. This has been a very interesting topic to discuss. So we will end the conversation here. For everyone who's needs to attend the following meeting. Anybody who would like to stay and continue having a discussion, we could hang out some more for a little while until it's bedtime. Thank you. Please let me know if you have any questions or if you're interested in participating in a cup of tea. My email's listed, ivana.ristevsky@sickkids.ca, and I'll put in the chat. And also, if you have any questions about child life, Morgan is our retinoblastoma expert, and you could reach her at morganlivingstone@rogers.com. And watch for our YouTube and Spotify. And as my son says, give us a thumbs up, subscribe, and hit the notification bell.
Nice, Nico. You're a good salesman, buddy.
Yeah.
Thank you very much. Thanks, everyone. This has been a great discussion.